Now, this slide might just surprise you. I know we're talking about overall gross heart anatomical structures, so that would be big structures. But I wanted to find a place that we could talk about the receptor sites that are involved in managing the cardiovascular and other core organs in our body that are kind of in between the microscopic level and the macroscopic function. And so let's pause here and take a moment to reflect on the receptor sites responsible for changes in heart, lungs, blood vessels, and other organs in the body. Now, at the EMT basic level, I think you learned about these. They're adrenergic receptor sites. One's associated with the heart, another associated with the lungs. And if you had a high rolling instructor or the time to read this much, then you probably learned a little bit about the vessels response as well. So these are receptor sites that are associated with the organ, and when stimulated will cause something large, big to change in that patient. Sometimes these are in response to disease, and sometimes they're the actual cause of diseases. To make these terms kind of easy to inch into, let's start with the beta adrenergic site. So beta adrenergic are stimulation in the autonomic nervous system on the sympathetic nervous system side. And so we learned about beta 1 and beta 2. Maybe the easy way to memorize these is beta 1 for the heart because you have one heart, and beta 2 for the lungs because you have two lungs. And then if you got that far, alpha for vessels. Okay, so let's start with our beta adrenergic. Beta 1 is associated in the heart, and it's going to increase inotropic and chronotropic responses. And so we're going to learn about those terms a little more on another slide. But basically, an increase in inotropy means an increase in the force of contraction. So that'll impact the pressure and the force of work that the myocardium does. The chronotropic is going to be responsible for changing the rate of the patient's heart. And so when you think of chronos, right? Chronos, that's referring generally to time as a prefix. It's telling you how quickly electricity goes through the heart in time, so that's a rate. Excellent. Beta 2 has an impact on blood vessels and on the patient's respiratory tract, though we'll talk about that in the respiratory section. It causes vasodilation in major blood vessels. Let's go to the alpha adrenergic site. So they're similar in the same system. They're part of the autonomic nervous system sympathetic division, but these receptor sites are physically different structures and so are stimulated differently and in different circumstances. So alpha 1 adrenergic receptor sites are associated with the vascular wall, so they'll also cause vasoconstriction. And in the heart, they can cause an increase in duration of contraction without increasing the rate, right? So that's basically saying the duration of the contraction can increase, but the rate or chronotropic effect will not change. And there may be reasons that you don't want your patient's heart rate to go up when you're managing, trying to get their blood cardiac output to change. When we talk about these receptor sites, we're talking about them because we likely can interact with these receptor sites through pharmacology, as you probably learned already at the EMT basic level. Things like epinephrine, albuterol will manipulate these adrenergic receptor sites. Now, we may not have talked about dopamine receptor sites at the points leading up to this class, so I'm just going to highlight it. We'll talk about it a little bit more when we get into medications next semester, and we'll also talk about it as a component of the renal system. So dopamine receptors work similarly, but they work in different areas. So they can cause, throughout a number of structures in the body, the effect of dopamine receptor sites being stimulated by giving a drug like the actual drug dopamine can cause vasodilation, vasoconstriction, depending on the amount of drug that we give. So these signs, primary type and subtype, are dose dependent. Okay. So we can get vasoconstriction in blood vessels out of dopamine receptor sites at the right dose for that patient, generally based on the patient's being an adult or pediatric and associated with the patient's weight. Great. So those are the receptor sites that are going to cause the heart rate to change, the blood pressure because of the force of contraction to change and the overall workload of the heart. If we give patients these medications in the wrong instance, if their heart can't handle the increases that we're forcing upon them, we may actually be causing the patient to go into an acute myocardial infarct, angina, or any other types of disorder because we're stressing the heart too much for the amount of supply of nutrients and oxygen that it can get access to. All right, that was a quick little jump. We're going to be reviewing that again when we get into pharmacology, and shouldn't be completely new to you, but dust off those bits of knowledge. This picture here shows the overall gross anatomical structure, and so we have a area where we zoomed in and we've got a cross-section of the structure of the heart. You can see the myocardium, the heart muscle, making that large band throughout the ventricles and a tiny band, essentially comparatively, in the atria. Endocardium, inside connective tissue, making the inside lining of the heart smooth. By the way, these folds go away when the heart gets fully engorged. It's kind of like the structure of your stomach. Those folds accommodate stretching and getting larger. On the outside of the heart, we have the parietal pericardium, the visceral pericardium, together making up the pericardial sac, essentially the membranes that are surrounding the outside of the heart. We have coronary blood vessels on the surface of the heart, all throughout its surface, not just on the anterior. And those blood vessels are usually embedded in fat, partly so it has access to emergency energy nutrients, and also can serve as some form of cushion. So make sure that you can follow an oxygen molecule from the outside world into the pulmonary circuit from the lungs, right? So you're going to start basically on the left side of the heart doing so. And all the structures that oxygen molecule would come to as you make your way through circuit, get CO2 back and bring CO2 into the vena cava, now spilling into the right side of the heart. So be able to follow that circle all the way through the structures listed here and others. The pericardium, as we talked about on the outside of the heart, membranes that are surrounding basically the entire heart and encapsulating it, actually have a space in between them. And that space allows for a fluid to become a lubricant so that when the heart moves inside its cavity, that space inside the pericardium, when the heart moves in that space, contracting and relaxing, expanding and getting smaller, when that occurs, if we didn't have some mechanism of lubricating it, friction would happen, and friction would lead to inflammation or irritation. So this allows the heart to work basically friction-free. But it becomes a problem if something like blood starts to leak into the space because of, say, a puncture wound from trauma or other forms of injury. And so if it's punctured, blood can enter that site. Sometimes it's leaving the heart's ventricle to get into that space because the heart was punctured as well. In either case, if that space collapses, the heart is compressible and the connective tissue is not. And so the connective tissue will not expand outward. The heart will have to essentially shrink inward, which restricts the amount of volume that the ventricles can expand to collect. So when that occurs, the patient is essentially suffering something called pericardial tamponade. Tamponade is kind of like a tourniquet restricting of flow, and the restricting of flow is because the sac is filling with fluid and it's outside of the heart, basically squeezing it from the inside in. Some terms here that we've seen before, the visceral and parietal. So generally the visceral is the membrane that's on top of the organ, and the parietal is the membrane lining the cavity that the organ is in. This highlights how the connection between the connective tissue and the overall structure of the heart, and when it intersects with blood vessels, is all basically connected. This here is showing fluid progressing, as we talked about, fluid accumulating or blood accumulating in the space around the heart, again restricting the volume, so decreasing their blood pressure as a result. Now, all of the muscle contraction that's kind of leading to the things that we're going to understand as normal function of the heart, all that muscular contraction is really well coordinated. Remember at the beginning of the lectures, we talked about how close the cells are together, and because that facilitates rapid depolarization, it seems like the whole tissue is working together. That's true, and that's what this slide is kind of answering for us. So if we just separate here atrial and ventricular for our bands, we're seeing the muscle bands that all of these cells come together to form, so that when contraction occurs, these muscles ring around each other, ringing like you're ringing a mop, right? And so if you look at the shape of the ventricle, it's from the bottom upward and the atria top down. Again, squeezing will cause fluid to go down, squeezing will cause fluid to go up. And so the heart doesn't just collapse and pump, it actually rings around itself. And so it kind of squeezes directionally and creates a spiral motion that gets all the blood out and out of the valves. Now, why is it that this all happens? Why is it that this occurs almost as if it's one large cell when it contracts? Well, the reason is, again, because they're so tightly collected together in intercalated discs. So unlike skeletal muscle, cardiac muscle has intercalated discs that bring them together. And at the junction of the cells where the intercalated discs occur, the cells can depolarize or conduct electricity from one cell to the next 400 times faster at the discs. This allows for very rapid depolarization of the whole chamber when it's time. Now, when those things occur for contraction, there were a number of other steps that went into allowing the contraction that we observe to occur. Part of those come from the unique characteristics of the heart. Now, remember, the heart tissue is muscle, so it shares characteristics with skeletal muscle for sure, like contractility. Now, I don't list contractility on my list of unique characteristics here because all muscle basically contracts. What we're looking for here are what are the unique characteristics of cardiac cells. So those include conductivity, the ability to take a signal from one neighbor and send it to the next neighbor. Automaticity, this is the ability to create your own beat. You can create your own beat by automating it. You don't have to rely on the other signal. So this allows the AV node to create its own beat as a secondary pacemaker and the Purkinjes to do the same. Rhythmicity and regularity kind of highlights that this occurs as a sequence of events that repeats itself. And so it does have a rhythm associated with it that we can observe both on the ECG, and if it's perfusing, we'll feel as a pulse. Now, irritability and excitability get, I think, interchanged pretty easily. The understanding that I have of them is to separate them by essentially what is stimulating it. So excitability, let's go there first because that's normal, right? It receives a signal through conductivity, and it's excited to then do the thing of depolarizing, which hopefully leads to contraction. Again, not always to lead to contraction, but that's what we hope is happening. So it's excitable to stimulus of cells nearby. Whereas with irritability, it can be stimulated by imbalances in the environment inside and outside the cell. And so irritability really gives rise to those PVCs we talked about, ectopic beats, in which it kind of just creates its own beat when it really feels like it doesn't have the things it needs to do its job. So that may be a PVC, but it could also be irritability leading to ventricular fibrillation, where the cells in the Purkinje fibers are just firing off because they're irritable, but they're not doing so in a coordinated manner like we saw in the PVC. Utilize the acronym CARRY to memorize these individual characteristics, and they'll certainly be on the exam. In addition to those characteristics, I wanted to just give us some pre-pharmacology terms that we actually saw already when we saw the receptor sites. So I won't be testing on these terms, but you'll see them in your reading pretty frequently. Inotropic is to describe the effect of the force of contraction of the ventricles contracting and ejecting fluid. And so if you have a medication that is an inotrope, it causes a positive inotropic effect, it means that the ventricles are going to work harder to squeeze harder and more forcefully eject blood. If we're doing that, we're probably trying to increase somebody's blood pressure that's inadequate. Chronotropic is referencing, again, chronos, the heart rate. And so if there's a positive chronotropic effect by a drug, it increases the patient's heart rate. And that may be beneficial, but it also could be detrimental in certain patients. Finally, dromotropic agents. And so again, used for pharmacology, a dromotropic agent will increase the speed of conduction, which is likely involving the electrical current at the AV node. So to memorize these, if you can memorize dromotropic as DC, right, like AC-DC current, it's conducting electricity. Dromotropic DC, it's conducting electricity, so it's talking about the speed of conduction. Chronotropic is purely talking about chronos, or time. And so it's how many beats happen in a time gives you memorization of the heart rate. This gives rise to the all or none theory. So either they'll all work or they will not. And so if a beat doesn't meet the threshold, then the rest of the heart will not do anything in response. If it does meet the threshold, then they'll all do so in response. We mentioned Frank Starling's law again. This is the rubber band theory, and really it talks about preload and afterload. And so one portion of getting a blood pressure out of the heart is to have good blood going back into the heart. So the return of blood through the vena cava and into the atria is one part of preload. But having enough blood then to squeeze and force the ventricles to engorge activates this next step. So this is a large increase on preload, and if we increase preload, we generally will increase afterload, which means we've increased the blood pressure. When the heart contracts and relaxes, these phases and terms occur. And so systole versus diastole. Well, this really makes up your blood pressure, right? Systolic is the top value of blood pressure and diastolic value is the bottom. And so this gives rise to the blood pressure in the sense that the top number, systole, is the work or contraction for blood pressure of the left ventricle. Diastolic is relaxation of the left ventricle. And so during the systolic pressure wave, the ventricles are contracting to generate a force that's higher than the standing pressure inside the circuit. That would be diastole. Diastole is essentially the pressure in our blood vessels after the ejection has stopped and the ventricles fill with blood for the next ejection. And so that alternation of systolic versus diastolic value is important in understanding the cycle of blood pressure. We're going to be utilizing to calculate more precise measurements of what the organs are seeing as far as the amount of perfusion pressure. And we'll also talk about this in relation to that big whole enchilada diagram we were talking about earlier, which comes up in a few minutes. You do need to know your valves. There's a few ways to memorize these. The valves need to be memorized as their name, the order that they occur, meaning where in the heart these are transiting to, and then what classification of valves they are. And so the first set of valves are atrioventricular valves, or AV valves. And these are the valves that separate the atria and the ventricles from each other. And so they're essentially opening to the right and left atrium through the ventricle through the atria, right? That's the idea. Now, the tricuspid and the bicuspid, tricuspid is the common term for that valve, but it may be called in our bicuspid valve either the bicuspid or the mitral valve. Now, when you're memorizing valves, you want to be able to do it backwards, forwards, middle, sideways, in all directions, right? So the first way to do it, though, is the tool I was given as a young student, is to memorize TPMA. Toilet paper, my ass, right? Toilet paper, my ass. Tricuspid, pulmonic, mitral, and aortic valves. But this only works in that order if you have blood going in and you're starting at the right atria, right? If you are talking about following the valves that oxygen would see after it enters the bloodstream through the lungs and then travels to the left side, we'd actually be working MATP. So be able to do it in both directions is kind of what I was getting at. The semilunar valves, their design is partly what gives rise to their name. They're found in the pulmonary artery and the beginning of the aorta. So essentially, these are the valves that are at the top of our ventricles. These valves have an ability to leak a little bit more because of their design than the atrioventricular valves do. The atrioventricular valves are the valves that are attached to papillary muscles with chordae tendineae. The semilunar valves are not attached in the same way. And so semilunar valves sometimes, if the valve is supposed to open and close this way, and it opens that way, and the valve pops down this way, we generally would think of that as being incompetent. That will allow blood to leak back into the ventricle that it's associated with. That will decrease pressure in the circuit on the other side, and it will allow blood to mix with the ventricle while it's trying to fill. And so the blood pressure and preload will probably go down to a degree. This is a picture from essentially the superior to inferior view, and you can see some of the valves located throughout as they've removed the structures. And so in this picture, you can't really make it out, but these valves are obviously out of a person that's deceased, but they may actually be diseased because they don't close all the way. If the valves don't close all the way, maybe not just because a valve has flipped the wrong direction, but because of something like stenosis, the patient will suffer the same consequence. Now, this is a really cool picture I like to include because this is a picture showing us inside of a heart, illuminated, the papillary muscles attached to chordae tendineae. And so the valve would be up here, atria would be here, we're in the ventricles as we're looking here, and that's associated with these. And so what happens is the papillary muscles are stimulated to contract. They draw open when they pull away from the valve to their tendon. They pull the valve down and open to help allow for more blood to go into that space. Another picture of valve function. We'll talk about semilunar valve functions a little bit more as well because that's inherent in the perfusion of coronary arteries. So semilunar valves is essentially where we're talking about for that coronary artery filling. The semilunar valve is going to specifically here be the aortic valve. And so you can see that as blood is squeezed out of the ventricle and up towards the valve bends open. But once the ventricle relaxes, blood will start to be drawn back into the space from the blood vessel, the aorta in this case, and that blood will catch these curved ends and force the valve to close. Now, once it's closed, the ventricle can fill again and get ready to eject blood, but the pressure went down a little bit as it went back this direction. A few disorders of heart valves include stenosis valves, which are basically a little bit more narrow than they should be. That might be associated with things like scar tissue or other disease processes. Rheumatic heart disease occurs when the accumulation or colonization of a strep infection occurs on the valve itself. It causes the valve to become inflamed and means that the valve may not close all the way and may have regurgitation of blood. Mitral valve prolapse is that valve that we mentioned in which the valve flips the opposite direction and allows for regurgitation at that point. It's most common in the mitral valve because its edges extend into the left atrium when the left ventricle contracts. So it kind of makes it prime if the pressure goes up too much, maybe in trauma because of explosive pressure on the chest, can cause that. Here's a picture of stenosed heart valve. You can see that it's pretty narrow and probably doesn't, obviously not in this person anymore, but probably didn't move freely to allow blood to flow through it. All right, now to prep for that big picture of the whole enchilada, let's talk a little bit about heart sounds. This isn't about teaching you to be able to say, this is the type of murmur that I hear. Really, we're teaching you to listen to a normal heart sound, and anything that's not normal really qualifies as a murmur. What will it mean? It could mean a lot of things, and we won't know often simply just by listening. So it's important that you listen to normal heart sounds so that one day you can identify, whoa, that doesn't sound right, because you've listened to enough normal heart sounds. Now, we generally talk about two primary heart sounds. Those are the first and second, or lub-dub sounds. Those are normal. We hear those sounds as valves open and close between each chamber. And so essentially, when we're listening at the fifth intercostal space midclavicular line, we're hearing these valves close and open and the reverberation of sound waves traveling through blood and through tissue till it reaches us. Now, if there's another sound outside of the lub and dub, we would consider that a heart murmur, and it may or may not be a cause of the call that they've outlined for you. And the patient may be aware or may not be aware, and it may not actually cause problems to them at all. In any case, it's something that a physician should evaluate. Now, again, coming back to this diagram, let's utilize some of that knowledge. So here we have our first and second heart sounds. And if we travel all the way down in this kind of brown line, we can see that sound is associated with the opening and closing of the atrioventricular and our other valves. That happens when the QRS is depolarizing, causing the ventricles to contract, right? They open when the ventricles contract. That opening is because of the pressurization that occurred inside the ventricle as it shrunk in size with the standard volume. So as that occurs, we can see blood moving through the body. Let's look first here. This has been essentially at the left ventricle. Let's look at the volume picture. So at the same time that the valves are opening and closing and our QRS is causing depolarization in the ventricle starts that right before the QRS with a total volume of blood within it, right? And that's essentially the preload. That's called our end diastolic volume. end diastolic volume. So that's the volume of blood at the end of diastole, or as we start the contraction phase. So it's full. And in order to get that blood into the body, we have to get rid of that volume, lessen that volume, by squeezing the ventricles. So as the ventricles squeeze, the blood volume will go down, and it reaches not a 0 point, but a small value called the end systolic value. The end systolic value is essentially the end of the contraction phase, right as the ventricles then start to relax, which would be the start of the diastolic volume. Now, the difference between end diastolic volume and end systolic volume makes up stroke volume. If you haven't heard of stroke volume before, it's part of our cardiac output formula we'll be discussing in a few minutes. So you can see blood is ejected in a pretty reliable way, and the amount or volume of blood that's ejected, if it's an average adult, is about 70 milliliters in volume for one squeeze. Now, the pressures inside the ventricle and the blood vessels are going to change, and if we have a volume that goes to a small space, pressure goes up. If we have a space that gets larger despite the standard volume or the lack of volume, then the pressure goes down. And so we should be able to see that when the QRS occurs and the end diastolic volume is now getting ready to leave the ventricle, the ventricular pressure should go up. And so as we see the left ventricle here in the bluish line, we see pressure go up slightly as the atrial kick occurs with our P wave. That's the atrial kick. And then as the ventricles squeeze and get rid of blood, the pressure goes up until it reaches the point that the ventricle relaxes. And at that point, blood will flow back from the aorta towards the ventricle and cause the valves to close. That releases a small bit of pressure into the aorta, which goes backwards. And then when it closes, it increases the pressure momentarily before the aorta now enters its decline in pressure as it's in the diastolic phase. The dicrotic notch is essentially the point that the aortic valve closes. So again, the blood in our body is circulated by a few pumps, and we can qualify those pumps essentially as being atrial and ventricular. But even further, they kind of have a role in left and right side pumps as well. This diagram's out of your textbook, and it shows basically the entire cardiovascular circuit throughout the body, including the pulmonary circuit and the systemic circuit. It's important that you know these major structures. I don't necessarily need you to memorize all of the arteries in the body, though there are important ones that we'll discuss. I want you to memorize, more importantly, that after we leave through the valves of the ventricle and we enter the systemic or pulmonic circuit, we're going through blood vessels. We could say artery or vein, whichever one's relevant, into venules, into our final capillary beds. And so be able to transition in that direction, talk about exchanging at the capillaries, both in the lungs and in our body, and getting CO2 into the blood and returning back through the heart into the lungs for exhalation. So understanding the blood flow in this circuit is helpful. Also, this kind of gives us a prelude to memorization of the blood vessels. Now, if you learned that veins carry deoxygenated blood, except then, well, you didn't learn a universal rule about veins. So let's learn some quick universal rules about arteries and veins that will help you memorizing which ones are in the lungs and which ones are occurring systemically. So the true thing about a vein is a vein returns blood to the heart. Right? Whether it's deoxygenated or oxygenated, veins return blood to the heart. So is that true in the systemic circuit? It is. The vena cava is the culmination of all of those veins now dumping into the right atria so that it can go through circulation and reoxygenate. It's deoxygenated there, but that's not what the constant of a vein is. So if a vein is always coming back to the heart, the pulmonary vein should be oxygenated blood going back to the left side of the heart. And we see that it is. Arteries are constant for arteries. Arteries take blood away from the heart. So now as you're memorizing, then you'll understand, well, if it's leaving the heart before it gets to the lungs, pulmonary artery, is deoxygenated, right? Sure, other arteries are oxygenated, but again, we now know our constants.